Siddhartha, finally a general medicine student. Today I'm going to present a paper on the title Incidence of Happy Hypoxia in in Coronavirus Disease 2019 patients in a tertiary care hospital. Co-authors Dr. Anjaney Prasad, VMD, Dr. Monica, SMD. Category Infectious Diseases. COVID-19 is a public health emergency of international concern with millions of confirmed cases globally. COVID-19, caused by droplet-borne SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, has wide clinical manifestations ranging from asymptomatic acute respiratory illness, respiratory failure that necessitates mechanical ventilation and support in an intensive care unit to multiple organ dysfunction syndrome. Some patients present with happy hypoxia, a condition where patients have low oxygen saturations as measured by pulse oximeter SpO2 less than 90%, but were not in significant respiratory distress and often appear clinically well, which misleads the assessment of severity. Aims and objectives: to study the incidence of happy hypoxia in coronavirus disease 2019 patients in a tertiary care hospital. Materials and methods. We collected data from COVID-19 patients attending to triage of Dr. Pisms and RF in the period of May 1st to 31st, 2021. It's a prospective study with a sample size of 1368 patients. Inclusion criteria: patient diagnosed as COVID-19 positive by RT-PCR and patients whose age is more than 18 years are taken. Exclusion criteria: patients aged below 18 years are removed. Results: of the total 1,368 patients who presented to the triage Dr. Pisms and RF in the time period of May 1st to 31st, 2021, 708 patients had hypoxia, among which 310 patients, that is 22.6%, had happy hypoxia. The following results were seen in these happy hypoxia patients. In coming to sex distribution, it was more seen in the males, 66%, and females only 34%. Coming to the age distribution, less than 40 years were about 20%, 40 to 60 about 54.8%, and 60 to 80 about 22.6%, and elderly about 2.1%. So more in the middle-aged people. The same in the as a bar chart. So majority were middle-aged adults, followed by elderly, and even in them, males were more affected than females. Coming to the SpO2 distribution, 91 to 93% about 38% were present. 81 to 90% SpO2 about 42.9% were present. 71 to 80 about 13.5% were present. 61 to 70 about 4.2%. 51 to 60 about 0.9, and no patients less than 50% saturations. The same in the bar chart. Majority were in the range of 81 to 90% saturations. Coming to the comorbidities, 28% of the patients were diabetic, 14% of the patients were hypertensive, 8% had chronic respiratory diseases, and 9% had other comorbidities. So majority of the patients were landing in diabetes, were diabetes. In this study, it was seen that happy hypoxia was seen significantly in middle-aged people, followed by elderly. Males were affected about 1.9 times more than females. Diabetes was the most significant comorbidity in happy hypoxia, amounting for almost 28% of the patients. Majority of the patients are in saturation range of 81 to 90% SpO2. The subjective sensation of dyspnea is driven by the respiratory center in our brain that is sensitive to increased carbon dioxide and to a lesser degree to decreased oxygen. Our respiratory center can become desensitized as we age and from chronic conditions such as diabetes. Patients with diabetes were noted to be 1.8 times more likely to have an impaired ability to perceive respirations than non-diabetic controls. Therefore, it was suggested that patients who present with happy hypoxemia are most likely the elderly and those with chronic disease, and consequently the poorest outcome. The remarkable dissociation between profound hypoxemia and clinically happy patient is frequently seen. In this study, a significant amount of middle-aged and elderly populations, especially males with comorbidities, of which diabetes mainly, were more prone to present with happy hypoxia. The physicians and healthcare workers should not rely solely on the patient's apparent well-being, but closely monitor his respiratory rate, signs of hyperventilation, oxygen saturation, and invasive measurements of hypoxemia at regular time intervals, irrespective of age and gender. As the paramount importance of measuring arterial oxygen content, either by the simple bedside pulse oximetry or arterial blood gas analysis, could not be emphasized in all the patients, including in all patients, including the asymptomatics. The limitations: the study was performed in a single hospital and hence limits generalizability to other populations.